right, everybody, welcome back. It's the time we've all been waiting for. We're about to bring on the show Dr. Joyce O'Shaughnessy. How you doing, Doc? It's good to see you.
Hi, April. How are you?
I'm
Good
doing
to be here.
awesome.
Good to see you and be here with your annual great program.
I know. It's so cool that you do this too, because I was looking back through, and I think last year you did like the 9:30 slot. I was like, I can't believe I've gotten you to do this so many times. It's such weird hours. So
happy to do it. No,
yeah,
that's early.
thank you.
That's early evening for me.
Yeah, and I was
It's
thinking
good.
about it. I think the first time you joined was probably like 2015 or 2016. So you've been doing this for many years. We really, really appreciate that
And many more to come.
so
Yes.
much. Well, I'm going to let you go ahead and, if you don't mind, giving an update on just like what's going on in the latest with breast cancer research.
Wow, it is a wonderful time. April, things are just exploding. And I think focusing on triple negative, and I'll kind of break this up because I think I'll focus on kind of the things that are going on right now, that are being applied to practice, because there's so much going on that are kind of in late stage trials or early stage trials that are a different animal, but there's so much going on just in general. So in triple negative breast cancer now, we recently, just in the last few months, got the mature final data from the Keynote 522 trial, which is the preoperative chemo trial for patients who present with stage 2 or stage 3 triple negative breast cancer. And we give the preoperative chemotherapy, and some years ago now, a few years ago, we started giving the preoperative pembrolizumab, which is the Keytruda, the immune stimulating agent. And we now have the final data in terms of what percentage women are going to be cured, basically, who we were not curing with chemo, and the answer is 9%. So we're definitely curing 9% more women. And so if you take the stage 2 and the stage 3s together, which is stage 2 is triple negative that's between 2 and 5 centimeters, and with or without a lymph node positive, and then stage 3 is above 5 centimeters. Usually you'd have lymph nodes involved then, but maybe not.
Right.
So basically larger triple negatives with the Keytruda and the chemotherapy. The chances of women getting to 5 years without any sort of recurrence, nothing in the breast, nothing new popping up, is 81%. And then if you look specifically at the chances of staying free of metastasis, it's getting close to 90%. So that's a really big advance. That's to see an extra almost 10% of patients cured is really, really good. And having really no more than 10 to 15% of women developing metastatic disease is really just a major advance in our lifetime. And there's trials going on. And one thing that's important too on that, April, is that obviously if gals get the preoperative chemo and the Keytruda, they go to surgery and there's no cancer left, nothing in the breast, nothing in the lymph nodes, their cure rate's 95%. And that's not unexpected, because if the chemo Keytruda can get rid of the cancer, that's, fairly large in the breast and the lymph nodes, then, it stands to reason that it ought to be able to kill off cancer cells that got out of that area initially and metastasize, microscopically metastasize. And so we do see a very tight correlation between having no cancer left in the breast and lymph nodes. That's called the pathologic complete response, and cure. It's not 100%, but about 95% cure rate. But the good news about the Keytruda being added to the chemo is that even for women who go to surgery, right, and they've had their chemo, they've had their Keytruda, they go to surgery, but there's still cancer left. And there could be a little bit of cancer left, a medium amount or a large amount. The Keytruda still improves the cure rate in those women. They don't do as well, obviously, as gals who have no cancer left when they go to surgery, but the Keytruda still improves the cure rate, even if they had cancer left. So that's also very, very encouraging. But so the next question is, well, hey, we still got these women who we haven't gotten rid of all the cancer. They go to surgery, they've had their chemo and Keytruda, they still have cancer left. We know they still have risk, and they have a medium to a lot of cancer left. They have still, unfortunately, a substantial risk of the cancer recurring. And April, that has turned out to be a very, very active area of research. Women get their surgery, they get their radiation therapy, and we know we're going to give them 6 more months of Keytruda, because in the Keynote 522 trial, we gave a year of the Keytruda, 6 months of it preoperatively with chemo, and then 6 more months of it, after the surgery. And so the question is, what can we bring in? What other medications can we bring in post-operatively to, kill off, to improve the cure rate for those women where we know it's likely they still have microscopic metastatic disease in the body somewhere because we did not clear the breast. And so, April, that's an area that there's 2 really important trials going on to further improve the cure rate of those women who still had cancer left. One's with the with a medication that's approved by the FDA, but it's approved for metastatic breast cancer. It's Trodelvy, sacituzumab. Trodelvy, which
is that something brand new since like a year ago?
No, we've had it for metastatic disease, April. I think we probably had it a couple, 3 years, but this trial that we're talking about, I think probably just got underway maybe about a year ago or so. And that's one of the things I wanted to mention to you. There's been another big advance, which is more for metastasized triple negative breast cancer, and that is the use of drugs like this Trodelvy. The generic name for Trodelvy is sacituzumab. We call it SASI for short. And what SASI is what we call an antibody drug conjugate. So it's an antibody. It's a protein antibody that you give IV. It goes through the bloodstream and it attaches to proteins on cancer cells, right? But then this protein antibody is physically attached to a very, very powerful, novel chemotherapy, different than the cancer has ever seen before. And what's nice about that is that you're not given just free chemo in the vein, which goes all over the body. You're just given the chemo that's attached to the protein. So it's kind of like more of a smart bomb, kind of like a drone that you can program to go right where you want it to go, And so there's much less toxicity associated because the chemo only goes to the tumor.
Wow.
Well, there's some, April, there's some, but much less than
right.
chemo. And so it turns out that now there are multiple of these antibody drug conjugates in clinical trials for triple negative breast cancer patients in the metastatic setting, but also in this curative setting where they go to surgery, they still have cancer left. We're bringing these antibody drug conjugates like the Trodelvy into the curative setting to see if we can, you get about 6 months of the Trodelvy IV once every, 1 week. It's 2 weeks you get it and a week you're off. So once a week, 2 weeks you get it and a week you're off. And so that is a very important trial. And then, April, there's another drug that's not approved by the FDA yet. It's honestly a competitor of the Trodelvy. It doesn't have a brand name yet. The generic name is Datto, Dato. We call it Datto for short, but it's Datopotamab, Potumab, Datto. And it's an antibody drug conjugate. And it's very similar to the Trodelvy because it actually goes after the same protein on the cancer cell, on the triple negative breast cancer, but it's a different antibody. It's a different antibody, but it goes after the same protein on the cancer cell. And then it's attached to the chemotherapy is attached to the protein antibody. And it's very, very, very powerful chemo. It's similar to the chemo that's on the Trodelvy, but different. And it's only given once every 3 weeks. It's even probably a more powerful chemo drug. So we're pretty excited about the Datto. April, it's in curative trial right now. So right this minute, we have it open at our center. It's open all around the country, many, many places around the world. A woman has residual disease. She still has cancer in the breast and or lymph nodes. After she gets chemo and Keytruda, she goes to surgery. She gets her radiation. And now the computer is flipping the coin. So it's a phase 3 trial. where the computer flips the coin, and half of the ladies get the standard of care, which is to get 6 more months of Keytruda along with the chemo pill, Xeloda, or capecitabine is the generic name. Xeloda is the brand name. It's a chemo pill. That's the standard of care, because it does increase the cure rate. April, does increase the cure rate. So half get the standard, and then half get the datopotamab, along with a competitor of Keytruda called durvalumab, which is Imfinzi. So very, very excited that that we're getting these promising agents so fast into the curative setting. So, it's only going to be probably a couple of years. We're going to have 2-3 years before we have results from these very important. And I'm very optimistic that for the women who do have residual disease, that we're going to be giving the Datto. One more thing that I'll say, and then about the triple negative with the Datto. Okay, so Datto's super powerful, and there's a trial that's been done for women with first line, getting their first therapy for metastasized triple negative breast cancer. Okay, so, and what they did is they put the Datto, they put the antibody drug conjugate Datto together with an immune stimulating agent, durvalumab, which is the brand name is Imfinzi, and they gave it. There was no randomization; everybody got it. Remarkable, like 80% of women got a very nice response.
Wow,
very, very powerful data. So what they're doing now, April, is they're bringing that combination, the Datto and the immune stimulator, the durvalumab. They're bringing those into the pre-operative setting. So it's the first thing the women get, the very first thing, and it's the first thing the cancer ever sees. Now it's randomized. It's randomized. Half of the women get the Datto and the durvalumab, and the other half get the standard, our Keynote 522 regimen, which is the 4 chemo drugs, the 4 standard chemo drugs with the Keytruda. So Datto is considered that promising, April, that's being brought just as a standalone treatment being compared to 4 chemo drugs. So that it's a very, very, and I think it's because it's the only way to deliver very, very, very potent chemotherapy agents. They're too toxic to just give them into the vein, but you can attach small amounts of them to these antibodies that go right to the cancer. They bind to the cancer. Cancer does not like having these proteins hanging off the surface of the cell, so the cancer sucks them inside to get rid of them. And as the cancer is destroying it, here comes the chemo bomb goes off inside the cancer cell. So that's why I think they're so powerful. They're targeted. Each of the antibody proteins can have 7 or 8 molecules of the chemo drug on there, and they basically just kind of let loose as soon as they get inside the cancer cell. Very
that's
powerful.
so incredible. It really
Yeah.
is. I love the way you're describing it. It makes sense, and I can visualize it happening. It's like we're going to war here on cancer.
Oh yeah. Oh, very definitely. Oh, no question.
Well, I don't want to forget to ask this. There's a couple of people who are watching right now who want to know if these drugs are the same thing as immunotherapy or if it's something different.
So the antibody drug conjugate, the Troddesivir and the datopotamab, they are not immune therapy, because basically what they're a very clever way to deliver chemo. So they're really like chemo, but just rather than give plain chemo in the vein, you give it only attached to these proteins. So that's not immune therapy. But when I was talking about Keytruda, and I was talking about the durvalumab, the Imfinzi, okay, those are the immune stimulant. Those are the immune therapy. So yes, and so with triple negative now, in the curative setting, basically anyone with stage 2 or 3 disease, so breast cancer that's more than 2 centimeters, everybody gets immune therapy unless they have a serious autoimmune condition, because the immunotherapy revs up the immune system. And if somebody has, bad lupus or bad Crohn's disease, you're trying to dampen down the immune system to get those, those illnesses under control. So you cannot stimulate the immune system. You'd really make someone sick. But other than that, everybody who's got stage 2 or 3 triple negative breast cancer is getting immune therapy these days.
So, like, I'm sitting here hearing this, and so if you're diagnosed with stage 1, is the standard of care still adriamycin and Cytoxan and Taxol? Is that still the standard of care?
It's one of the standards of care, April, and I think it is the most common standard of care if the breast cancer is, above a centimeter. So it's 2 centimeters or less is stage 1. So, and it's the most common that if it's 1 centimeter above, sometimes you'll find these little cancers that are a centimeter or less, on a mammogram or an MRI, and they're really quite small. And a lot of times what we'll do is we'll go to surgery first to really see, how big is this thing, exactly, and to make sure there's no lymph nodes involved. So April, if someone comes back and they've got a triple negative breast cancer that's a centimeter or less, or maybe a hair over a centimeter, but it looks favorable. What does that mean? Favorable means no negative, of course. With triple negative breast cancer, the faster it grows, that is, when you look under the microscope, the greater the percentage of cells under that microscope that are clearly dividing, the better they die, the more effective the treatment's going to be. Another very favorable thing you can tell, April, is if you look under the microscope, the pathologist does, and the cancer is being swarmed with immune cells. The immune cells are in there. They're paralyzed. They're not killing, but they're in there. Tumor infiltrating lymphocytes. The more the cancer has of those, the easier it is to cure it. Because what happens is, here comes the chemo. The chemo starts, blowing apart the cancer cells, and now the immune system can see it. Now the immune system can say, "Oh, this is foreign. We got a foreign issue here," and the lymphocytes are already there. So those are very, very highly curable. So we can tell the favorable ones, and if we have one of those, what we try to do, April, is avoid the adriamycin, because adriamycin has a very rare risk of a long-term issue with the heart, very rare, and even a rarer possibility of causing leukemia, like 1 in 1,000. So there's a different regimen, April. It's the Taxotere with carboplatin regimen. And we know if it's under a centimeter in size, we give 4 cycles of Taxotere, and carboplatin, it's IV once every 3 weeks. And if it's a little more than a centimeter, you might give six cycles. So that's a regimen that I'll tell you. I'll just mention this so you know, is that there's a trial that has recently started. It's called the Scarlet trial, like Scarlett O'Hara, and it's being supported by the National Cancer Institute through one of the cooperative groups called the SWOG. And what it is it's for stage 2-3 triple negative breast cancer, where the Keynote 522 regimen, the chemo plus the Keytruda, is the standard preoperatively, right? So the computer flips the coin. Half of the ladies get the standard chemo Keytruda, it's 4 chemo drugs plus Keytruda, and one of those chemo drugs is adriamycin, and the other half, April, gets 6 cycles of this Taxotere and carboplatin with Keytruda, getting rid of the adriamycin. So instead of 4 chemo drugs, it's down to 2 chemo drugs, and they get it IV once every 3 weeks for 6 cycles. And the reason they're doing that is because Dr. Sharma, Priyanka Sharma, who's one of our country's best triple negative breast cancer researchers at the University of Kansas, she did a clinical trial where she gave women, instead of giving them the Keynote 522 regimen, she gave them 6 cycles of the Taxotere, carboplatin, and Keytruda. And then they went to the operating room, they went to surgery, and the percentage of ladies who had no cancer left looked just as good as the Keynote 522.
Wow, so there's a future of the death of the Red Devil. Is that what I'm hearing?
Let's pray.
Yeah, that's awesome.
We're working our way.
Yeah, that's amazing. Yeah, so those people watching, we were talking about this a little bit earlier in case you joined late. the adriamycin is what people refer to as a red devil, and you actually see that go in. And what's funny is after you have that chemo, they tell you, hey, when you go to the bathroom, you're going to be able to see that when you urinate that it's going to be red, and all the stuff is just so crazy. And so yeah, but that's the one thing that everybody complains about the most, is because
the
it's
first thing.
so
Do I have to
exhausting.
get the red devil?
Yeah, exactly. I know, it's like whoever came up
We're
with that,
trying to
it's
kill
like,
it. We're trying to kill it
yeah,
off.
that's
Yeah.
so cool. That's very cool. Wow, what a great combination. I've heard all of those medication, all those chemos, medicines before, but I've never heard them described in the fashion that you are, and how they level up to one another. So that's super cool. So at what point you were saying, for stage 2 and 3, is that the ones where you were saying they start to get an immunotherapy like the Keytruda or something else in addition to?
Yes.
Okay.
In addition to the chemo, that's standard now, April. Yes, immune therapy is for basically every triple negative woman, stage 2 or 3, unless she's got a serious autoimmune condition.
Gotcha. And out of curiosity, Dr. O, I was looking through some websites, and it seems like a lot of places give different percentages. But what is the percentage that you know of women that get triple negative breast cancer out of all breast cancer diagnoses?
If you put everything together, put everybody together, I would say it's about 15%. However, if you look at the African American community, it's higher. April, particularly in premenopausal African American women, but also postmenopausal African American. It might be 25% of breast cancers in the African American. I got a slide that gives me the exact number, but it's like bar graphed, and it's, the African American women get more triple negative than non-Hispanic white women and Hispanic women do. We have no clue, April. We have no clue why that is, but yeah, and so the good news about African American triple negative breast cancer is that triple negative seems to be responsive to the immune therapy. And so this is very good. This is very good because, it's a more serious breast cancer. Now, if you cure it, it's phenomenal. I mean, by 5 years, basically, and certainly by 8 years, a woman knows if she's cured. The problem with estrogen receptor positive breast cancer that's fed by estrogen is that, that stuff can go back 20 years later, and so, yes, the risk of it coming back goes down and down and down and down over time, but still it's not 100%, but with triple negative breast cancer, if women are clear of disease at 5 years later, they're like 98% cured, and they get to 8 years, they're 100% cured. So, but if you don't get cured with triple negative breast cancer, if the cancer is not responding to the therapy, then unfortunately the lifespan is short, basically, so, so bad news, the African American women get more triple negative breast cancer. Good news, it's responsive to the immune therapy, so, but yeah, it's about 15%. In April, we still don't know why people get it. Now, the only thing I will say is that in women where breast cancer runs in the family, it's a BRCA1 gene, can be BRCA2, but mainly BRCA1, maybe PALB2, BRIP1, RAD51D. There's certain of these genes that run in the family, like it's hereditary breast cancer, that for reasons we don't fully understand, the kind of breast cancer those women get is triple negative breast cancer. Because one of the things about triple negative breast cancer that makes it unique is that it can't repair its DNA. And that's hereditary breast cancer. The cells have a lot of trouble repairing their DNA. And so they pick up a lot of mutations and they get more aggressive, but that's the one thing we do know, April, in terms of why this stuff happens, is that it's hereditary breast cancer. It can be ER positive. Like BRCA2 tends to be estrogen receptor positive breast cancer, but there's a bunch of hereditary genes that tend to make triple negative breast cancer. But other than that, we don't have great data to help us understand why people get this this particular type.
I'm so glad that you pointed that out, about that African American women not only get it more frequently, but on the good side, it's usually has a better response. That's so good to know. I have a friend, Kim, who was on last year, and she was diagnosed, and I've been, I just, concerned about her as much as anyone else. But the fact that, she probably has a more responsive version is so great to hear. You know, you're
Yeah.
talking about the different genes and the BRCA1, and how a lot of times familial genes will play a part in triple negative breast cancer. You know, I was tested not that long ago. I want to say it was 30 something genes. How many genes are they now tracing back to
Yeah.
breast cancer?
Some of these tests, April will even do 50 to 80 genes. But honestly, if a woman has had, even 17 to 30 genes, and it's been done by one of the big companies, I can list them for you, and it was done 2016 or after. See, before 2016, a lot of the genetic testing was literally just BRCA1 and 2, and it wasn't our most modern evaluation of BRCA1 and 2. So when I see ladies in my practice now, April, me and my nurse practitioner and physician assistant, we're looking to see, okay, when was the genetic testing done? Because literally every woman who's had triple negative breast cancer, every one of them needs genetic testing. And it used to be, April, that we used to have to send the women to the genetic counselors, and then they would do the evaluation on the family and decide, was the woman high enough risk? We don't do that anymore. There are multiple diagnostic companies now where you can, where we oncologists just send the tube of blood. Now I'll tell you what I've been doing, and this is, this is true for other companies too, but for sure I know this one. There's a company called Natera, Natera, and the name of their hereditary blood test, looking for one of these many genes, is the name of the test is the Empower test, EM and then power. And it's very, very clear. Natera's business model is they take whatever insurance gives them, or if insurance gives them nothing, that's what they take. They don't bill patients. They don't expect any money. They don't expect the women to pay the remainder. So that is fabulous. No one's going to be stuck with a big bill. So I am very aggressive now about redoing. If somebody had it done before 2016, I just redo it. Okay. And then, so I think they do 80 genes, April, but I think, honest to God, we don't know what to do with most of these. And the thing is, if you test too many of them, you get variants. You have these variants that come back, and it's blue eyes, brown eyes. We're not even like, yeah, we got a variation. You got blue eye gene. I got brown eye gene. Those are variations, but they're not harmful. You know what I mean? But so they'll come back with these variants. So I think it's probably better to stick to the 17 to 20, 30 genes we know something about. But anyway,
Yes.
it is rapidly evolving, basically. And then I will say one more important thing is that if a woman is found to have one of these genes, one of these hereditary genes, April, then it's very important, in my opinion, and other people's opinion, to go to a genetic counselor, bring the family, and go and find out, okay, what does this mean? What am I supposed to do for me? What does it mean for my family? What kind of cancers are we vulnerable to? So that's the role of the genetic counselor, is to, and the genetic counselor will give the woman who has the breast cancer, she's got this gene, they give them a letter, dear family members, I have been found to have such and such gene. It's rare, but it can cause, breast cancer, ovarian cancer, colon cancer. Attached is my report. Bring this to your doctor. It's very inexpensive to get it tested. If you know where to look, it's like a couple $100. And so they walk the women through how to notify the family that one of these genes is now in the family. So that's very, very important. That's how you save lives. You prevent the cancer from happening.
Well, all that stuff is just so proactive. I love that company isn't requiring the patients to pay anything, and they're just taking whatever insurance will pay for. It's super proactive in the fight against breast cancer and other cancers. It's very, very cool. I wanted to mention Paige Nally is here. She's got breast cancer, and she says, this is great information. I wish you were my oncologist. You're very knowledgeable and clearly stays current. She says that she's intrigued that you use the term cured. I guess because because everybody says cancer is incurable. So I think she's, yeah.
Oh no. See, that's the good side of estrogen receptor negative breast cancer. So that's triple negative. So triple negative, of course, is negative, does not have the estrogen receptor, does not have the progesterone receptor, another female hormone, and does not have that aggressive gene, HER2. And then, so that's one type. The other kind of estrogen receptor negative breast cancer is ER negative, PR negative, and HER2 positive. Okay, HER2 positive, we got very good therapies, but those are our two types of breast cancer that are estrogen receptor negative. Okay, the thing about those cancers is those cancer cells die very well. In general, they die very well with chemo. But the other thing is those kind, the estrogen receptor negative, those are the kind that the immune system sees. The immune system can kill them. I mean, I'm talking get rid of every last cell. So we actually consider those two kinds of breast cancer curable. Now, if it's already metastasized, to a vital organ like, the bone, liver, lungs, or something, we unfortunately don't consider it curable. Although, having said that, there are some women who live out their life and they, in fact, are cured, but it's a very small percentage. So we are very cautious about saying cured in the metastatic setting, although it's not zero. But in the early stage setting, stage 1, 2, 3, those two cancers, most women are cured, like about 85%. With triple negative breast cancer, if you add in the stage 1s, it's probably close to 90%. And then for the HER2 positive, estrogen receptor positive, estrogen receptor negative, HER2 positive, the cure rate there is similar. It's probably 85, 90%. Cure.
Yeah.
I'm talking cure. No cancer for rest of life, basically.
Yeah. I love that. I remember the first time you said that to me when you said, well, you're cured. I was like, what? I was
what do you
so
mean by
excited.
that now?
Yeah,
What do
but
you
I
really
mean, if anything, it just gave me so much hope and encouragement, which is something that someone having just gone through that really, really needs for sure. So, Dr. O, what do people have to, like, what is the prerequisite to be accepted into one of the trials that, like, you're conducting?
Well, there's, and this is what I'm going to tell you about my cancer center is true for every cancer center. Okay. So let me tell everybody how to do this. So, and you don't even have to have a particular clinical trial in mind. The process is, to call your local cancer center. And, but you can, if there's, I'm going to tell you a little bit more refined way to do it, but, you call your local cancer center and you ask to speak to the oncology research coordinator, breast cancer research coordinator. And then you say, hey, I'm trying to find out if I'm eligible. I got triple negative breast cancer. I'm trying to find out if I'm eligible for a clinical trial. And the research coordinator will get your records. And then they'll look at the records and they know what trials they have, and they do the matching to see if a woman is eligible, meaning she's got the characteristics they're looking for in the clinical trial. Now, another way to do it, it's a very good website, clinicaltrials.gov. And you can just Google in clinicaltrials.gov and it comes up. It's kind of like a Google box. And you type in triple negative breast cancer, and then they ask for a second word, and you could put in antibody drug conjugate, or you could put in Datto. You can put in Datto, or you could put in Troddesivir if you know what it is, or you can just put in triple negative breast cancer, and you can put in stage 4 if that's what you're looking for, or you can put in stage 3, and then you press the button, and they make a big long listing of all of the trials in the US, and you can look through them, and if you're looking for like the one I talked about, the Datto, for example, or the Troddesivir, you can find them, and then at the end of the summary, you open up this document. At the end of it always is a list of the cancer centers around the country that have that trial open. And so you can find out, is it anywhere in Texas, for example, or wherever you live, and they give you the phone number of who to call, and sometimes the name and the phone number of who to call. So, and you can even just Google it. You can Google, like, for example, you could Google triple negative breast cancer, residual disease after surgery, clinical trial.
Gotcha.
And the Troddesivir one should come up, and and now we got ChatGPT and Gemini and all the things that can really help us out here,
Right.
And they give you the contact person to call.
That's very cool. And I was just looking through the people who are watching right now. I know Jennifer, Aquarius, Paige, and others have all had breast cancer that wasn't triple negative. So about probably half the people watching are triple negative breast cancer survivors, and the other are breast cancer survivors in general. And I would presume that the instructions you just gave would be similar for somebody who had any kind of breast cancer.
Any kind of, looking for any kind of clinical trial. Absolutely. And when in doubt, you just call, and they'll figure it out. They'll get your records and figure it out.
So do oncologists, like, say you reach, you're with your oncologist, they're like, hey, we gave you everything we could. Is it common for the oncologist to suggest a trial, or does the patient have to ask, or does it just depend on the doctor?
It depends on the doctor, and it also depends on the situation. And because sometimes the oncologist may not know about the newest trial that's been open. For example, if somebody gets the preoperative chemo and Keytruda because they got triple negative and they have residual disease, they still have remaining disease in the breast or lymph nodes, the doctor may not know, hey, we got 2 clinical trials that bring in the Troddesivir and bring in the Datto. And so they may not know that. And so it's always a good idea to say, is there a clinical trial for me? And because then the doctor, a lot of oncologists have clinical trials in their own offices, but they know who to contact. Like my Tex Oncology partners will contact me or one of my partners, because we focus solely on breast cancer and have a lot of trials. If you're an oncologist, no matter where your oncologist is, your oncologist will have a colleague that they reach out to who knows the breast cancer world very well and knows the trial. So, because a lot of the oncologists who are general oncologists, they really see all solid tumors. There's just such an explosion of information, thank God, and new treatments for every kind of cancer. There's no way a general oncologist can keep up with all the trials that are going on. They can barely keep up with all the new treatments coming because it's very, very, it's very rapid progress. So, which is fabulous. But so it's always a good idea to ask, and because it's very easy for the oncologist to reach out to one of their colleagues and find out if the patient's eligible.
That's super, super powerful information. I know that there's a lot of women out there who have metastatic breast cancer or other kind of cancers out there that feel like they're at the end of the road, and it's always good to know that there may be another option for you or something you could try. And like you said, it's so promising, Dr. O. I'm so glad you're able to join this every year and give us an update, because each year just gets more and more promising in this field.
There's so much going on this year. April, I could go on for about another hour easily about now some of the investigational things, but there's vaccines, there's CAR T cells, which is a form of immunotherapy, a couple of promising responses in women with bad chest wall disease all over the chest wall with a CAR T called ROR1, ROR1. That's an immunotherapy. It's a very aggressive immunotherapy. For example, BioNTech, the company BioNTech that brought us one of the 2 COVID vaccines, Pfizer developed the BioNTech vaccines. It's a vaccine company. They have their own vaccine. They have their own triple negative vaccine that'll be going into trials for sure in Germany, because BioNTech's based in Germany this year for sure. But BioNTech has a lot of money now because they saved the world. Pfizer, BioNTech, and Moderna and AstraZeneca and others saved the world. And so they have a lot of money, and they are putting money into very promising cancer agents. And one of them was at our recent San Antonio meeting in December. And it's what we call a bispecific antibody. So it's an antibody protein. Bi is 2, right? 2 specifications. It's an antibody protein, 2 specifications, meaning that the antibody binds to 2 separate things, 2 bad things that make the cancer grow and takes them out. One is VEGF, which makes new blood vessels. And the other one is the PD-L1 that dampens down the immune system. So it's immune therapy, but it also stops new blood vessel formation. And it looked fabulous. It looked fabulous in early trials. So there's so much going on. I love it. It's really, really an exciting time.
Well, I love how passionate you are about it too, Dr. O, because you're able to speak in such a clear manner for those of us on this broadcast to really understand what's going on, and it also gets us all excited too. And every year I always do this to you at the end because I always want to have this included in our talk. You always give some great information on how to reduce your risk of recurrence or how to reduce your risk of breast cancer in general. Can you let everybody know those things right here?
Sure. No, there are definitely there's always two pieces of breast cancer, right? There's the breast cancer, and it's intrinsic aggressiveness or lack of aggressiveness, etc. But the other part that's super important that we need more work on, quite frankly, but we know some things, and that is the overall health of the woman. So, and that means probably means many things we don't even, there's so many things we still don't understand, but we do know that considerable weight gain, 10% or more weight gain after a woman is diagnosed, increases the risk of recurrence in a woman who's had breast cancer. For a woman who's not had breast cancer yet, post-menopausal weight gain increases the risk of breast cancer, not premenopausal, but post-menopausal weight gain increases the risk of breast cancer. Alcohol is pretty serious stuff. We got to be careful. It's okay to have a couple, 3 drinks a week. It is not okay to have 2 drinks a day. Alcohol is a substantial toxin in all kinds of breast cancers. The risk is increased. And furthermore, if you've had breast cancer, it's safe to have 2, 3, 4 drinks a week. Less than 1 a day is what they say, less than 1 a day. But, a lot of alcohol every day is not okay. It increases the risk of recurrence. One thing I'm going to put out there, and this is absolutely proven, and that is the very, very prolonged use of the Mirena IUD. These are these IUDs, that have hormones in them. And, there's only a small amount of hormone. It's mainly just at the uterus, to prevent pregnancy. But it's proven very, very clear that there's a tiny bit of hormone that gets out into the bloodstream. And it's a hormone that's like progesterone. And progesterone kind of stimulates breast stem cells, our granddaddy cells, And I see a lot of ladies who have no reason to have breast cancer. And they're usually between ages, 40 and 55, just in that, transition time where the breast is starting to turn over, the normal cells are dying off, and the breast is supposed to be turning from densely glandular to fatty, as we get older, around the menopause, 45, 55. And so the dying off process. And if you've got this Mirena IUD, you've had it 20 years and a lot of alcohol, it's just like, it's the perfect storm. I see a lot of gals walking through the door have breast cancer and like, wow, you have no family history, you have no this. So I tell people to, use those really only when you need them. If there's times in your life you don't need them, what have you, don't use them. And when you finish childbearing, consider getting a copper IUD or getting your tubes tied or something like that, or have a husband get a vasectomy or something, because just, constant hormones all of our life is not a good deal, basically. And that's really kind of proven. It only increases the risk a little bit when you put that across a population, because the Mirena IUD is a very common contraception. When you put that across populations, you're going to have a lot more breast cancer. So I tell people, try to stay minimum on the hormones, low alcohol. If you drink at all, low alcohol, and try not to gain 10% or more body weight. One thing I'm going to mention, let's say a prayer here now, that the Mounjaros and the Zepbound and the Ozempics of the world for our women who have had breast cancer and they're obese. And the problem with obesity is very, very difficult to lose weight if you're obese without these medications. And furthermore, obese women or substantially overweight ladies that are getting close to obesity, they tend to gain weight because, our breast cancer treatment slows people down. They don't feel good in the stomach, so they eat a little bit more. The anti-estrogen pills slow the metabolism. We get older, our metabolism slows, and so people are gaining weight, and it's very common in obese or overweight ladies for them to gain 10% or more body weight. And I've been super frustrated over the years because we don't have any ways to help the women except maybe a gastric sleeve, or one of the big gastric surgeries. But I'm super hopeful that the Mounjaros and the Zepbounds and the Ozempics of the world, where women lose a lot of weight and then they have to keep it going. They have to keep the medicine going, but they keep it off. This
is the shot that a lot of people. Okay, yeah, I have I think 4 friends that are doing those shots right now. So, and that's there's not been anything negative as far as in the oncology world, right? Yeah, that's great.
No, it's I consider that safe in our breast cancer world. But and then lastly, April, is that the Harvard Nurses Health Study has been following tens of thousands of nurses who have had breast cancer in our country for decades, and they've long follow-up, and they say that they have found out that the nurses who are walking on average or doing some sort of exercise that gets the heart rate up 3 hours a week had a 50% less chance of dying of breast cancer. So it can be swimming, it can be yoga, it could be Pilates, it could be stationary, but whatever people like to do. It's unfortunately not the running around the office that I do some days. It's really more sustained heart rate up, but it doesn't have to be. It's not heavy. You can be conversational about it, but that's really big. The circulation and exercise lowers so many things that can increase the risk of breast cancer recurrence. So those are really, really important 3 things: weight, exercise, and low alcohol. And then I'm throwing in there, really prolonged use of Mirena IUDs. I don't mean 8 years, but I'm talking, lifelong use of these things, not recommended.
Good. That's awesome. I love having that in here because we will post this on our YouTube channel. People will be able to rewatch this and this one as well on Facebook. I have one more question in here that I'm going to slip in, and then we're going to have to go because I know Madeline is waiting. She's up next right now. Somebody asked if you recommend an anti-inflammatory diet.
Yeah, we don't specifically recommend one because we don't have data yet. There are studies going on, for example, with a keto diet in preventing breast cancer recurrence. That's ongoing. There are studies going on, but I will tell you this, that when women exercise and lose weight, when they lose weight, by whatever means, the inflammation in the body goes down substantially. So it's not so much the specific diet, it's the weight loss that really lowers inflammation. And we want to, this is now getting a little speculative here, but we want to take care of our gut microbiome. There are these crazy studies in patients with metastatic melanoma, where they give somebody Keytruda, the immune stimulant, the immunotherapy doesn't work. And then they give Keytruda to somebody else, metastatic melanoma, and it works. You know what they do? They take the stool, the bowel movement, the stool from the man or woman it worked in, and they can desiccate it. They can desiccate it, put it in capsules, and they can, the person with the Keytruda did not work for eats those, and it changes the microbiome. It changes the bacterial content and balance of the person's gut. Then they give them Keytruda. It works.
Wow. That's crazy. Like, how they come up with this? I'm just saying, wow.
Take care of your microbiome. Don't have antibiotics willy-nilly, and eat cultured yogurt and kombucha and blue cheese and sauerkraut, pickled. So look for foods that can support the microbiome and try to avoid a lot of antibiotics. And so that's speculative. We need more studies on that for breast cancer. But it's really known that there are certain gut bacteria. There's certain good gut bacteria and bad gut bacteria that will actually determine whether immune therapy works for somebody. They know this in melanoma and a little bit in lung cancer. They don't know it yet in breast cancer, but we know there's good bacteria and bad bacteria in balance, and different colonies in the gut that predict for whether immune therapy is going to work or not. It's crazy, but true. So that's going to be coming too. So we just want to be aware of our gut microbiome.
Wow, that's really interesting information and powerful stuff, man. Dr. O, thank you so much again for doing this so many years in a row. And this is our most treasured time because we get the latest and greatest from you. And I can't wait to chat with you again next year or sooner.
Sooner. And April, thank you, as I always thank you every year. All of your colleagues for all the fundraising and education you do for everybody. But you really not only disseminate information about research and opportunities, you support it. You and your colleagues support it too. Greatly appreciated.
We always will, Dr. O. We always will. I'm so excited to see the big steps you guys are making out there. And thank you so much again for everything you do.
Take care. Good night, everybody.
Love you, girl. Take care.
Bye, everybody. Bye now. Bye.
All right, everybody. That was Dr. O, man. What a rock star, right? So awesome. So awesome. All right.